Hi. Hi, Andrea.
Hi.
Hi, well, everybody, welcome to the OCD and series. Andrea, thank you so much for being my first guest on the pilot episode of the OCD and series, where we talk to people around the Sheppard Pratt system who are experts in different types of treatment and different conditions that people struggle with that often come up within the context or around OCD, which is my specialty as director of the Center for OCD and Anxiety. So I wanted to get a chance to talk to you first because I often find when I'm working with people with OCD that they have difficulty with emotional regulation. Sometimes it's because of an underlying personality disorder, and sometimes it's just because emotions are really difficult to regulate sometimes. Can we just start with, give the audience just a brief intro of who you are, what you do at Sheppard Pratt, and then we'll get into the details.
Yeah, and thank you so much for having me. And it's so exciting to be the first person for the series. I really appreciate that. So I am Andrea Gottlieb. I'm a psychologist, and I'm the director of the Sheppard Pratt DBT program, Dialectical Behavior Therapy, which is an outpatient program treating people with BPD, intense emotion dysregulation, and the problems that go along with having trouble with regulating emotions. And so I think that's going to end up actually being a big part of our conversation today, probably.
Do a lot of people come to your program, already with a diagnosis, or are they coming to you because an event occurred in their life where, their emotions got out of hand and they acted impulsively or something like that, and someone said, you need DBT? Like, how do people know to come to you?
There's so many avenues to us, and you're listing some of them, right? So sometimes people have big events and cannot handle them. And typically, it's not a one-time event. Typically, the people who have trouble with big events that make their way to me have this happen over and over again. So maybe they've been hospitalized numerous times, or maybe they live with chronic suicide ideation or self-harm. Other patients have diagnoses given to them by professionals, BPD, PTSD, or a combination of many diagnoses. Bipolar 2 is sometimes what people are diagnosed with, and people think emotion dysregulation there, or a lot of anxiety. And they do their research and they find that DBT is a treatment for them. So people are coming to DBT from a lot of different places. And when I think about the diagnoses that people have, OCD is something that I hear sometimes as well.
Yeah, so it sounds like it's mostly people are coming to you after kind of either themselves or somebody else has picked up on a pattern of difficulty for which there might be a system of treatment that can address that pattern, as opposed to one event and then it's like you need DBT. It's more like, seems like something keeps happening, and
definitely
you have they're not getting there for you.
Yeah, and most people don't make their way to DBT as their first treatment either.
Interesting.
That's not common. It can happen. It might be that they're living life in some miserable way, living in misery, and then find their way to the hospital, and someone says, "Oh my goodness, you have so many symptoms, so many experiences of the kind of emotional misery, and then the behavioral manifestation of that DBT might be a fit for you." And but that isn't common, at least in our program.
So for the audience sake, kind of understanding the two areas of psychology where we work. So in my case, working with obsessive compulsive disorder. So this is people who have unwanted intrusive thoughts, and they have rituals or other types of behaviors that they get stuck in, trying to get certainty about those thoughts and reduce the stress associated with those thoughts. And the treatment of choice, my area of specialty is cognitive behavioral therapy, which involves challenging the way you look at your thought process that leads you to these behaviors. And then the behavioral part of that is what we call exposure and response prevention, which is strategically confronting those uncertainties and really kind of retraining the brain to be able to tolerate it and navigate through it. And it necessarily involves, in many cases, dealing with dysregulated emotions, because that's often what they're trying to avoid. I don't like to think this thought, or I don't like to be around this trigger because of the way it makes me feel. And so I'm in the business of training people to get in front of those feelings and work with them. And so there's a lot of crossover, I think, with DBT, which is also related to CBT. Could you talk a little bit about what DBT is and how it's different from the type of CBT that I do?
Yeah, and I would say it's more similar in some ways than different, for sure, which is, I know why we've had some conversations before
Right.
that, where we can talk for probably a really long time.
Well, and we should talk about why people think it's so different too, because I think that's a problem. I think people in the psychology world are like, this is my camp and this is your camp, and I do this and you do that.
Yeah. So DBT, dialectical behavior therapy, is a treatment that was created by Marshall Linehan, and she essentially realized that in treating people with chronic suicidality, with BPD, with intense emotion dysregulation, that a change approach only, the evidence-based treatment at the time was mainly CBT. Pushing too much on change, do differently, think differently, feel differently, led to a lot of pushback, essentially.
So you're
or at
telling
least
people,
this is the story I know.
You're telling people, essentially stop doing this, it's bad for you. And they're thinking, obviously if I could, I would, and this is invalidating and it's actually making things
exactly. Yep, exactly. You're another person telling me that everything about me is horrible.
Right.
At least that's what goes through my patients' minds if there's too much kind of push for change. So on the flip side, kind of fragilizing people and just sitting there helping them just accept misery and lack of change, then doesn't make lives better. And as I was kind of alluding to, a lot of my patients have chronic problems in their lives, unrelenting crises. They don't go away. So she created this treatment that is really a combination of CBT and mindfulness and acceptance, as well as what we call the dialectical synthesis of those, which is sitting in kind of the middle point, the synthesis. So DBT is a lot of focus. How do I say this? There is a strong focus on learning skills, learning how to do things differently, because people hadn't learned how to handle their emotions effectively, or they kind of know what to do, but they can't get it into their lives. So we're teaching and we're generalizing skills. And then in individual therapy, we're kind of helping people learn how to implement that and deal with their problems. The skills very much so are about making change, doing things differently, being able to face a feared thing like you were just describing, and sitting in the distress of it, sitting in it, tolerating it, accepting it.
So that's actually what that word dialectic means, right? I've always heard it's two opposing ideas or opposing forces that you're holding in the same space. Mm-hmm. And it sounds like what the central thesis is that you can accept something and also change at the same time. That they look opposing on paper, but they're actually part of the same thing.
Exactly. And in some way you have to do both, right? To change, you have to accept.
Right. Because in mindfulness circles, I talk about change, I talk about forgiveness, and the instinct is always to think like, well, if I just accept things, well, I'll just let the world burn around me, and I'm never going to stand up for what I believe in. And if I forgive this person for the harm they've done, well, then it's like saying that what they've done to me is okay, right?
Yeah.
As opposed to actually looking at, well, how much are you investing in anger, and what's that doing for you? Or, Yeah.
And acceptance isn't actually about forgiveness. It's not about getting over something, right? It's actually about acknowledging and being with something. So say you got into a fight with someone and we're using acceptance as a strategy, it would just be acknowledging that this was not okay to me and we didn't agree, and that upset me. I felt anger, I felt betrayed. And the other person has their side of what they felt and what they experienced. And so just allowing that all to be there without having to make it okay is actually, the moment of acceptance.
You mentioned things happening to people or behaviors that keep coming up, and it got me thinking. You mentioned BPD or borderline personality disorder, and then there's sometimes I wonder about in BPD there are things that people are doing out of desperation or because they're not really sure how to get their needs met or how to communicate, and it's causing this dysfunction in their life and it's causing more pain. And then there's trauma where there are things that are just happening to them. They're not the ones doing it. But so in both cases, there's sort of traumatic experiences that are occurring. One, you're more sort of directly involved in because maybe there's skills that you haven't learned. And the other is, it's sort of luck of the draw. The universe just isn't cutting you any slack, and it's having this negative psychological impact on you. Can you talk a little bit about those two disorders and how DBT kind of helps with both of them? So you have a treatment that you just described as, teaching people skills and teaching them to both accept and figure out ways to change.
Yep.
And then you have conditions where, one person's having dysfunction because of things that they're doing, not because they're fools, but because it makes sense to them in the moment because they're being guided by their emotions or distorted thoughts. But it's obviously not working out for them. It's leading them to hurt themselves or destroy relationships or things like that.
Yeah.
And then you have people to whom things are being done. They're being abused, they're being harmed in some way. And so they're being traumatized. And the end result is the same, which is they're thinking, life is too hard. I can't handle this.
Yeah.
And so I guess my question is sort of, and maybe there's no real answer to it. It sounds like DBT is really about teaching people how to handle things, whether you caused them or whether they were done to you. The end result is the same, is that you're in a position where you think it's more than you should be expected to tolerate.
Yes, for sure. So I guess my thought here is, I don't see them as distinct necessarily. I see it all as part of the experience, and that the same strategies help with both of those two sides, where it's generated by the person kind of, and like you evoke the responses in your environment, right? And then there's the environment kind of does a thing to you, and you have a response to that. And all of it, so, thinking about the idea of a personality disorder, it's that you have a style of interacting with the world that is maladaptive, and it's across settings, across many years of life. And I guess, that underlying idea, and in DBT, we kind of think about the biosocial theory as the underlying theory for how people develop to have emotion dysregulation. So they're kind of born with or develop the biology to respond with high emotion, sensitively. And then the environment continues to throw things at them, including invalidation. Right. So then they learn to interact with the world in a way that tries to get their needs met, get emotion down, make my point, have people understand me, have people listen to me, help me achieve this thing that I want to do that I just can't get to do right now because of different things, right? So it's a style of interacting with the world that doesn't really move towards effectiveness. Yet it's what the person knows how to do to try to get their needs met. So yeah, what we're trying to help people do is make change, do it differently, learn to be skillful, learn to be effective, and at the same time, acknowledge what's happening, sit with the facts, be there in unpleasant, right? Like sometimes people want their lives to feel better, and when I really get them to identify what better means, it means to them without any discomfort.
Right.
We both sit here knowing that's just not possible.
Well, it's one of the things I notice in a lot of my clients with OCD is that they view their experience on the whole as being negative. Like, my life is negative, it's bad, it's full of these bad thoughts.
Yeah.
And many of them, have lots of difficulties that you can say, okay, that's objectively bad. But what I see a lot of is, if you kind of think of the experience as, you're sitting here and these experiences are passing by, and then there's just something that you just have identified as intolerable. I refuse to have that thought. I refuse to have that feeling. It becomes so distracting. You're off here kind of working on it, trying to get rid of it through compulsions or avoidance or reassurance or some other means. Meanwhile, life is still happening, and all of the good things, the flavor of your food and like the sound of music and things like that you would enjoy, you're missing out on because you're busy on this other project. And when you come back, you're like, see, life is unbearable. Like, if you could just stay long enough to watch that negative experience come and go, you might be there when the next positive experience arises. Maybe,
So that's where DBT and your OCD treatments that are CBT oriented are completely overlapping.
Coming at it from the perspective of, okay, you're doing this thing, recognize that as compulsive, whether it's ruminating or reassurance seeking or cleaning or whatever the compulsion might be, drop that, come back to this discomfort, this uncertainty. Just stay long enough. You'll see it passes like everything, like us, it passes. And then maybe something else will come along. So DBT also kind of uses that model in a way. That
is what I am aiming to get people to be able to do, actually. It's just a different flavor of it, right? So if I were to think about the emotions that come up that I work to help people sit with, typically it's shame, guilt, fear, sadness, with a few others thrown in. But those are like, and the shame and the guilt are becoming, I don't know if it's like, when you have a nail or when you have a hammer, everything's a nail. But I just feel like so many people have problems like allowing themselves to feel shame and guilt, and especially when trauma's in their history. So a lot of what I'm doing is identifying what emotion it actually is. So uncomfortable, discomfort, overwhelmed, feel bad, like that doesn't actually help somebody get past the moment well, because those are all judgments, right? And you've kind of alluded to that, like this moment is bad, I need to make it go away.
Right.
Instead, we try to understand it. We try to understand where it's coming from, and then just watch it and don't do the compulsions to get it down, right? So whether it's ruminating about the bad parts of it, or blocking thoughts, or dissociating or disconnecting, or doing a harmful behavior, because guess what? It changes my attention and it immediately drops the sensations in my body. And there is physiological data to support that too.
I would guess some of the conditions that aren't OCD that might be co-occurring with OCD, like borderline personality disorder, as one example, that's when they come into play, right? When you're on the receiving end of some kind of trigger, or maybe while you're doing your exposure therapy, right? In ERP, we say, well, let's go after these emotions. Let's go after these difficulties. Let's practice being with them. Let's seek them out. Let's create circumstances where you're more likely to experience them so that you can get better at experiencing them. And sometimes I've noticed with people who have co-occurring disorders like BPD, they're doing the work and they're doing a great job, and they're dealing with something like disgust or a sense of contamination or fear-related uncertainty about whether a bad thing will happen. But then this monster comes in that we didn't expect to come in, called shame, and it completely commandeers the therapy. And unless they have the skills to work through that shame, it just tanks the exposure therapy. And it creates this feedback loop. I've seen this multiple times where we might be doing something that I and the client both agree is totally doable. We've built a hierarchy and they're ready to do it and they're confident they can do it. And they go and they do it and they say, okay, I'm doing it and I can handle this and this is all right. And then something about it brings up that shame or that guilt.
Yeah.
And suddenly they're not in that experience anymore. They're only in the shame and guilt experience.
Yep.
And
that's where their mind is too, right?
And they feel bad because this was supposed to be easy. If I can't even do something easy, wow, I'm just really defective. And so the whole conversation has changed because shame, came into my office and took over my session. Shame. So this is where I think, okay, well, there's some other skill besides just keep doing the exposure and wait for the shame to go away. That's needed. Something other that we could bring in. And this is where I start thinking, okay, well, maybe this person has an underlying personality disorder, or maybe they don't. They just need some other skill besides exposure and response prevention to help them not abandon the project because shame came in.
And in, if you were to ask me to say one sentence for what I would do with shame, or what I do with shame, it's the exact same thing that you're doing in ERP. So it's allowing it and just watching it and not doing anything with it.
Does that include, not, analyzing it, like, trying to make sense of why the shame is there or where the shame comes from? I mean, are you observing it just in the body sense?
No, so observing and watching can also be about recognizing where did it come from. So kind of that, we do formal chain analyses in DBT, but once someone knows how to do that, we can do these little informal chains where we see, oh, I did the exposure, I did my my OCD exposure, and then you tell me what would come next, actually. How do you get to shame?
Right. Well, sometimes they don't even know. Like, well, I don't know what you're shamed about. You're doing great work, like, but sometimes it might be something like discovering that the exposure was harder than they expected. And because it was harder than they expected, this other voice came in that says, you're a loser. You can't even touch this little dirty thing.
Okay. So that's, So then I did this. It was harder than I expected. My thought was, you're a loser. I'm a loser. I'm no good. Shame hits. Now I'm in shame. Right. So observing that, and then we can go back and start to observe when that thought comes up. Of course, shame's going to come. It's just what happens. If I have a thought that, and I would, just to kind of be very nuanced here, I help people also pick apart which is shame and which is guilt. And the perspective that I help people come at it from is that shame is kind of focused on being worried that you're breaking a social norm in some way, or the norm of like a dynamic between you and another person. So this person is judging me for doing something wrong, essentially, versus, and the sensations with shame, that stomach drop. I don't know if you've ever felt it, or if people describe that to you, the like heavy drop all of a sudden.
I think of it as always imminent. It doesn't happen as often as it used to, but it could happen at any moment.
Yes. And then guilt, on the other hand, is I'm breaking my values, my my hopes for myself. And actually guilt is kind of more like up and jittery. And so guilt and fear sometimes are confused by people.
Well, I've sometimes described guilt as anxiety about the past and anxiety as preemptive guilt about the future, right? I'm going to mess something up and I'll feel bad about it. So they play off of each other.
For sure. That makes sense. Yeah. So, like observing, this is what I felt, this is what happened, this is where it came from. And then I had this thought. So of course, if I have this thought, this emotion is going to follow. So let me just let it be here and let it come down when it's ready to. And if instead of interacting with it.
Right.
So yes, observing it does entail looking back a little bit, but once you've learned the chain, then you can observe the chain happening and just let it be.
Yeah, and that would make sense too. I mean, forgive my kind of inherent nerdiness here, but I'm thinking about like something like a horror movie and how you could watch it and think, oh, this is the most terrifying thing ever. How could anybody watch this? And have it be a completely different experience from looking at the storyboard that went into creating the scene before they shot the film, which isn't scary at all, but has all the same content. And you're just, well, okay, so then they're going to put the camera here and the actor's going to stand there and they're going to use this special effect and then it's going to cut to this scene. And so that's not scary, even though it's the same content. And so it's just about taking that shift. That's what when I think of chain analysis, is like looking at the storyboard of the experience.
Yep. You're looking at it and you're trying to figure out where did we get on this track? Where, what were the key variables here? And then we can treat that. And so what I think you're identifying is that as you're treating the OCD, sometimes shame is coming up on that chain to kind of derailing the effect of the ERP.
So let me ask you a question. It might not have an answer, but when you see somebody's in shame, either because they've been triggered by their OCD in the way they didn't expect, and now they're kind of immersed in this story of something's wrong with me, and you recognize it as a clinician, and then you say, well, okay, so let's do a chain analysis. Let's investigate this. Let's experience this, and then because they're so immersed in the shame, they become very resistant. They view that as a form of invalidation too. You're saying, hey, you're not doing anything wrong. This is shame. Let's work with it. And they're hearing, you're doing something wrong. Why are you ashamed? And that's not what you're saying.
Yeah.
Right. So how do you work with people who, when they're so immersed in it, that just whatever efforts you're making to help them still feel like more invalidation?
Yeah, I think I do have an answer to that one, actually. So just trying to think, like in session, what I do is I stop them and I'm like, hold on, we're just going to sit here in this. Tell me, and I do a quick little mini exposure of like, close your eyes and feel, just notice, right? And then I say something like, and it has to be natural in the moment, of course, or else it is felt as invalidating. But like, oh, we just caught something really important here. Because it seems like, or you just identified that shame is coming up after you do the exposure. And so we now need to make sure to tackle that, because you're doing all of this right, and then shame is coming in and derailing it, right? Just like, I remember back to when I first learned about ERP, but maybe it wasn't ERP, I don't know. Maybe, the first memory I had in grad school of like learning about OCD treatment was also being able to call it something, and to kind of, I have this memory, sorry, I'm gonna go off on a tangent. There was an older student, and he would always tell the story of treating a kid who had OCD, and they called the OCD monkey butt, and I will never forget it.
Right. When we're treating kids with OCD, we often externalize it so that they can kind of think of it as their competitor or their opponent, or something that they have can exert some power over, as opposed to just being them.
Which I know is also, we see that in a lot of different therapies. We see that in IPT, right? Where you kind of name depression. And I think we see it in the kind of ACT-oriented treatments, where we observe the thought process as kind of this outside factor that's happening.
Think of it as an evolution, especially when working with adults. You can start by saying, my OCD is making me do this, or I'm having an OCD thought about that.
Yep.
But that's actually the beginning of learning how to, from my point of view, of how to evolve into being able to say, like, no, this isn't OCD's thought. This is my thought. It's just, I have all kinds of thoughts and I don't have to take them all seriously. It's like, if I get spam email, that's still my email. I just didn't want it, right? I don't have to say that something is happening to me. It's just happening, right?
Yep. So that's exactly, like, so now we've identified shame as a thing that happens that is very natural, very normative. We know that there are common emotions across time, across cultures, across races, across ages, and shame is one of them. And it happens, and it's actually adaptive. Who doesn't, maybe not who doesn't, but most people want to be kept in the relationships and crowds that they value, right?
Right.
So shame comes up to try to protect and keep you in those relationships.
Right. It cues you into thinking, maybe I'm not good enough, and I'm going to be removed from this group, so I need to do better.
Yep. So what happens is, in your situation, shame doesn't fit, right? There's nothing shameful about struggling with ERP.
Right.
But the person's mind, because that's what they're used to doing, tells them that. So now it's this process that is part of you, and it's a thing that we can just watch happening, as opposed to being in it and it taking over.
Switching gears a little bit, this is things always fascinated me about borderline personality disorder. There's certain characteristics. One of the things that's a little bit frustrating just about the diagnosis is, right, there's 9 criteria, and you meet 5 of them to get the diagnosis, and the 4 you don't have, you might not relate to at all, and you might think, well, why do I have to have this label of that if like almost half of the things that make that up are something that I would never do in a million years, never think in a million years. So that's just one thing I've always been curious about, is how to kind of work with the shame of the name of it, because when you have a name for something, you can get the treatment for it, and that seems like a good thing. And unfortunately, with mental health stigma still being where it is, and we're making progress, but we're not there yet. It's like, you could say I'm depressed, or you could say I'm anxious, but then when you start saying you have OCD, well, that has some implications for how people look at you. And then when you say you have borderline personality disorder, that people have very strong reactions to that. Which is very unfortunate. But that's not my question. Like, just a comment there. One of the facets of borderline personality disorder has to do with dysregulation of self, and this kind of sense of, I don't really know who I am. And I guess a lot of the shame comes from that. You're just talking about how, I belong in this group, or I want to belong in this group. Wait, maybe I don't belong in this group. Maybe something's wrong with me and I'm getting kicked out. How do I know I belong? How do I know I'm a good person? Or how do I know, what my values really are? Or, any of these things that make up a me, how do I know what a me is? And what I see in a lot of OCD, particularly the intrusive thought and primarily mental ritual forms of OCD, obsessions about sexual identity, obsessions about whether or not they might commit an act of violence or would want to hurt themselves or not, or something like that. There seems to be a lot of crossover there because they're struggling with on the OCD front with that uncertainty of, how do I know I won't just turn my car into oncoming traffic, that I'm not this like spontaneous, impulsive, horrible person, just commit an act of violence for no reason. And I want to know, and I have all these compulsions for making sure that doesn't happen. I avoid driving, or I drive only in the right lane, or something like that, as an example. And most people without this borderline symptom can kind of look into their hearts and go like, well, I know deep down who I am, but sometimes I have doubts because of my OCD, and I have to work with that, and I can do exposure to that and overcome those doubts. But some people look into their hearts and they open up that book of the book of me, and there's like blank pages, and they don't feel like they have something to hang on to. Yeah. And that's something I've seen a few times, that OCD BPD hybrid, where the OCD is saying, hey, there's uncertainty about who you are. What are you going to do about it? And they don't have that foundation under there to say, no, you know who you are. This is just your OCD. How can we help people have that problem? And am I right in sort of how I'm describing kind of the BPD experience of like not having that grounded sense of a true who I am?
So my first thought here is part of where that comes from is the chronic invalidation over time in life, right? If who I am is wrong, then who should I be? And when you think about gender dysphoria, not, non-binary or trans experience, of being born into a body that doesn't feel right, and then being told constantly by your world, but that is you.
Right.
Or what trauma does, that, if you think about chronic traumas, chronic sexual trauma continuously kind of invades your body and therefore your sense of self.
Right.
And so people can learn to not trust what they're experiencing inside.
And I see that happen in OCD as well. It often takes over a decade before you get treatment. So you have all these people who are living with this thought that maybe I'm a closeted serial killer, or a closeted some other thing that I actually don't think I am, but my brain keeps telling me maybe I am. And I'm reaching out for help to people who don't know anything about OCD, and they're saying, stop it. You're worrying too much. That's nonsense. And in my heart, I'm thinking, no, something is really wrong here. And so that's another kind of invalidation, is you're not being taken seriously, you're not being understood. And it would just make sense that if you're being repeatedly invalidated over years, that sense of invalidation of like, I'm obviously not meant for this world, has to concretize in your personality. And that becomes a disorder itself, right?
Yes, like I think about also how people can teach themselves to block feeling inside, and block, and when I say feeling, I don't necessarily just mean emotion. I mean noticing desires, noticing pleasure, noticing the things that are interesting and exciting. So what you're describing definitely lines up with the way that I think about this as well, which is, if decades, right, of hearing, just stop, like get over it, and then reaching for more doesn't work, just try and stop it. Let me just try and not go there. Let me try and block it. And then that becomes a learned pattern. So then being able to turn to yourself and say, how do I get through this? Who am I? Doesn't work. And so then you just latch on to other people. Fine, you tell me.
Right. And in OCD, that just stop it message internalized becomes, don't think that thought, don't let anybody catch you thinking that thought, don't have that feeling.
Yep.
And of course, that creates, that sends a signal to your brain that, wow, this thought's really a big deal. It's really threatening. You can't handle it. And so it makes the OCD worse. So trying to hide your OCD both makes the OCD worse and then also provides the ingredients for developing some of these conditions for which DBT is really important.
Yep. No, I'm giggling inside. I don't know if you noticed that. Do you know the Bob Newhart "Stop It"?
Yeah, absolutely. Yeah.
We talk about that a lot in my household as a joke.
Yeah.
Um,
yeah, exactly.
Yeah. It just, all of this is learned patterns. Our biology, our environment kind of guide us in different directions. But, so some people develop the need to ritualize. Some people just sit there and beat up on themselves constantly. And then that becomes where they go to. So I think we're seeing different flavors of the same process. It just takes a different path because we're all human and we're all different.
And yet we're all the same, and yet we're
we're
all suffering. Yeah.
And therefore predictable in some way.
Are there any situations where DBT for a person with OCD where they, my understanding of DBT is that a part of it, the skills part of it, involves a lot of acronyms, a lot of how kind of almost setting up kind of concrete conditions for here's how you interact with this situation, here's how you interact with that situation. And if you can remember the acronym, then you find yourself in that situation and you're about to kind of lose control, and then you realize, wait a minute, I can use this program that I learned to navigate through it. Are there any contraindications there for someone with OCD who might be prone to compulsively using, like, I have to use this skill every time, or I have to use it in a perfect way? Does that ever come up in your work?
I don't see that a ton. I've seen it a little bit. DBT is more nuanced than that. The answer to everything in DBT is, well, it depends.
Right. It doesn't work. Right.
So I need to know everything before I can tell you what the right answer is. But in fact, I don't actually have the right answer. You're the one that knows. Your wise mind knows. So, if it's kind of like every time I feel anxiety, then I use opposite action skill, that's not nuanced enough.
Right. Can't be every time. I get this question all the time. How do I respond to my intrusive thoughts? What do I do? And I always give, I'll give you 4 options, but you can't use one of them every time, or that becomes a problem. You can ignore them. You can be mindful of them, meaning you can acknowledge them, but not respond to them.
Yeah.
You can comment on the uncertainty around them, like, yeah, okay, maybe I don't know, and get back to what you're doing. Or you can kind of comment affirmatively in an exposure kind of way, like, yep, that's totally going to happen, can't do anything about it, and then go back to what you're doing. But if you rely on any one of those 4 responses to your intrusive thoughts in the OCD world over and over and over again, they all come with cons. They all come with negatives, and you don't want to build up the negative part of that.
And we don't just want to get emotions down.
Right.
We don't want to just be not able to respond to emotion, because I use an example. If one of my little kids runs across the street, then I need fear to jump in and have me pull them back. So if I teach myself that I need to get fear down, then I'm not going to respond effectively. And that's just a simple example, but
no, but it's a perfect example, because one of the questions that comes up in the OCD world is, when is it okay to bring those emotions down? Or when, I try to explain to people when I'm going through the initial obsessive compulsive model that, not everything you do to reduce distress is inherently compulsive. Right?
Mm-hmm.
What I think of as a compulsion is a thing that you do to reduce distress, specifically by trying to get certainty about the content of your obsession. So if something triggers you and you become distressed and you decide to take a couple of deep breaths, and that helps reduce your distress, but it doesn't actually do anything with the content of the thing that triggered you, I don't think of that as compulsive at all. I think of that as a good idea, right? On the other hand, if something triggers you and you become distressed and you go on Google to make sure that it doesn't mean you have a disease, that might bring down your distress, although it probably won't. But if it does, I would think of that as compulsive. Can you define sort of the difference between emotion regulation and emotion suppression? Or emotion removal?
Yes. So emotion regulation is about, I'm going to use the not specific definition first, but then go into it. So getting control of your emotions versus your emotion controlling you. So sometimes we want to get the intensity down or the duration of it down because that is not effective or because it doesn't fit the situation. And so therefore the emotion doesn't make sense. Sometimes we want to regulate emotions by allowing them, right? We can reduce suffering through acceptance. And so one tool for regulating emotion and getting control of your emotion is actually acknowledging, allowing, and sitting with it, like we've been talking about. In addition, understanding, right? Being able to accurately identify the emotion and where it's coming from, the different parts of it, or as I talk about, like getting clues to your emotion, that stomach drop sensation. I'm feeling shame. So all of that is about regulating and getting control of emotion. We also can kind of reduce vulnerability. So I know I get hangry. If I don't eat enough for breakfast and then 11 o'clock hits and I'm in a session, I have to just notice that I'm a little more irritable, right? So one way also to get control of emotion is to manage those vulnerability. So that's kind of emotion regulation. Suppression of emotion is trying to immediately get it down, turn it off, shut it off, distract from it.
Bury
right?
it, essentially, right? Keep yourself from feeling it.
Keep yourself from feeling it. They're actually really different processes, in my opinion. I think what gets more confused is regulating emotion and distress tolerance also, right? So what does it mean to tolerate emotion? Actually, we're talking about doing nothing but being with it and not making things worse. So people sometimes think to tolerate my emotion, I actually need to get it down and regulate it.
Right.
And in fact, we teach people how to tolerate it by allowing it by soothing themselves through it, by getting the like intense physiology maybe down, but not trying to make the emotion go away.
That sounds like a really important distinction, that you could do something to reduce the intense physiology of an emotion without actually shoving the emotion itself down. It's almost like the intense physiology part of it is on the outside, and you're allowed to remove that as long as you allow the inside part to remain. Because in the ERP world, I always try to get people to do exposures, and I always tell them, the point of all of this is to learn that you don't have to do compulsions, and you can't learn anything if your brain is on fire, right? Yeah. It's like, at a 10, at 6 to 8, very uncomfortable. There's some great learning going on there. You're going to be very alert, because, and that's, but you have to still be there for it in order for it to matter. So the next time it comes up, you can recall, oh, this is something I don't like and can handle, as opposed to something I don't like and can't handle. So if you're at a 10 out of 10, I'm going to pull you out of that exposure and say, all right, let's take a few breaths. Let's back up. Let's get back down to an 8 so we can get back to work. Because you're not really here.
So I think, back to your question of like what becomes contraindicated or when does it get confusing or problematic, it's when using one idea that I'm having right now is that I could imagine you wanting to help somebody get that physiology down so that they can get through it. Although actually my understanding is you want them to sit with it and habituate on their own, right?
Well,
or no?
I want them to be able to be there and experience it. So if they're so distressed that they begin to dissociate or hit themselves or something that's like not a part of this project, then I want that out of the project. So does that make sense?
It does. Yeah. So the skills to like get physiology down are the tip skills. So we're using cold water on our face to activate the diver reflex. We're using paced breathing where we breathe out for slower than we breathe in. Maybe do a little bit of paired or progressive muscle relaxation. So what I was thinking is I would be worrying in someone who's prone to compulsions that this would become safety behavior.
That's the challenge, is how can I get somebody intentionally into a state of dysregulation so that they can learn that they don't have to be compulsive just because they're anxious and triggered.
Right.
But keep them in that range.
Right.
And if they have a tendency to go outside of that range, give them skills to bring themselves back into that range, but not think, oh, I'm not allowed to feel this. I need to go do some deep breathing.
Right.
So it can get tricky. Yeah.
Definitely. Yeah. I mean, breathing is a really useful tool for sure.
I think breathing should always be allowed. Can we just say that? Like, there's no OCD therapy where, or DBT therapy where you should be expected to hold your breath, unless you're specifically working on interoceptive exposure to panic or suffocating. You should always be allowed to breathe no matter what's going on.
That's too funny. Yeah. I mean, and there are different techniques that are taught. And actually I often have people come to me having learned, and I'm not bashing this type of breathing, but having learned a version of square breathing where you breathe in, you hold, you breathe out, and you hold. And I'm always perplexed that someone's trying to do that as a tool for when their emotion is super high, they're breathing fast and feeling panicky. Because in my kind of learning, you want the breathing to continuously cycle, and you want it to slow down so that you can get your heart rate down and get the shakiness down. Probably doesn't have one holding their breath.
Right, probably. Yeah, I could come up with a couple examples where that might be an intentional thing you do, but
exactly.
not very many.
Yeah, so the other thing, I knew there was another thing I wanted to say, which is distraction.
Right, that's a tricky one too.
Because we teach distraction in DBT.
Yeah. And we say that we don't teach distraction in OCD, but we do. We just do it. We use different words.
What are your words?
Well, if somebody's engaged in a mental ritual and they're trying to figure out the meaning of their thought, and that's their compulsion, and they have the option to go watch TV and engage in a show that they really like, that is a form of distraction. And I want them to do that, because when they finish that show, they will have accomplished something. They watched a show. When they finish ruminating, they haven't accomplished anything. They've just been ruminating. Yeah. So getting out of a thought process can absolutely involve distraction. The distraction we don't want is the kind that kind of like whatever the psychological equivalent of walking around with blinders would be, right? Like, oh, I had that thought, don't think about it, right? That kind of distraction we don't do. Or like, I don't want to do this thing that's anxiety producing for me, so I'm just going to lock into my video game instead. That's the kind of distraction we discourage. Yeah. But absolutely, if you're down the rabbit hole with your OCD and you can do anything else with your attention, that anything else is a better use of your time. And that might just be a distraction. I think the difference, because what you're saying is what I teach people for distraction. My difference is if I want someone to distract from a self-harm urge. If I want someone to distract from a self-harm urge, I'm fine with them narrowing in on that other thing. They can do as fine detailed artwork as they want to, or play a video game, but it has to be time limited. Right, that makes sense. Yeah. If the problem is something like rumination, or having thoughts that are problematic, or a lower level urge, like wanting to go tell somebody how horrible they are. Right, pick a fight with somebody that they have some conflict with. Yes. Right. So then I don't want, like, maybe I'm more along the lines of what you're thinking of. Right. But if we're trying to get people to not do something that could be really dangerous, my choice is go do that like really narrow distraction if that's the only thing you can get yourself to do right now. Yeah. With the idea that we're gonna get that out eventually. Yeah, well, and it makes sense. You're giving the brain just another project to work on for a little bit. Yeah. In the hopes that the CPU will cool down a little bit and start functioning normally again. And then you can tease apart, do that chain analysis. How did you get to that point where you thought maybe I should hurt myself was a good option? Yeah. Yeah. Well, Andrea, thank you so much for your time. This is a great conversation. This went exactly how I hoped it would go. Okay, good. And I learned a lot about DBT and the variety of disorders you treat. I actually learned some things too about OCD as we were talking them out. So this is fantastic, and I hope the people watching get a lot out of it as well. Thank you so much. I hope so too. Thank you for inviting me. This was really fun. Take care. Bye. Bye.